Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers. Today, where we are on GLP-1s as a treatment for addiction. I'm joined by Dr. Sarah Kawasaki, an addiction medicine physician and chief of addiction services at PennState Health. We talk about what's currently known about GLP-1s as part of treatment for all kinds of addiction, including alcohol, opioids, nicotine, and even gambling, and perhaps more importantly, what we don't yet know. Let's listen. Dr. Sarah Kawasaki, thank you so much for joining us on Public Health on Call. How are you?
Great. How are you?
I'm doing pretty good. I'm very excited about this topic. We've gotten a lot of listener questions about this. We're going to talk about GLP-1s specifically around addiction. But before we get into that, would you please just tell us a bit about you and your work?
Sure. So I'm Sarah Kawasaki. I'm an addiction medicine doc and internist at PennState Health. I'm medical director of an opioid treatment program where we treat individuals with opioid and alcohol use disorders. We use all evidence-based approved medications for both conditions at that clinic. And we also do some research, including researching whether adding GLP-1s to existing medications can enhance treatment for opioid use disorder.
And so let's talk about GLP-1s, and our audience will be familiar with them, but could you just give us kind of a crash course in what they are and what they're primarily used for?
Sure. So GLP-1s were initially developed as medications to help individuals with diabetes. These medicines are called glucagon-like peptides that promote satiety in the areas of the brain that stop us from thinking that we're hungry. In doing that, it can enhance the ability of insulin to take glucose out of the bloodstream, and that reduces the diabetic load for individuals with type 2 diabetes. These drugs developed about in the 1990s is when they first came out. There were first generation GLP-1s, and then they started to become more and more sophisticated, and it was found to be quite useful in weight loss. And so it started to be used more commonly for weight loss in individuals who did not have diabetes, in addition to individuals with diabetes. And in those trials, some of the analysis that was done after the fact found that many of those folks lost their taste for alcohol. And this got very interesting to some alcohol researchers, and they started looking at GLP-1s to treat alcohol cravings and found that generally people did well with alcohol use. They drank less heavily and drank fewer days of the month when they were on it, but only for people with BMIs in the overweight or obese range. So not in individuals who had normal or low BMIs, which was very interesting. And then, once people get excited about losing weight and losing the taste for alcohol, people start wondering, well, how can it be used in other substances of abuse? So around the time the studies on weight loss found that individuals were also losing their taste for alcohol, people started doing a lot of preclinical work. So in other words, work with lab animals on other substances of abuse like opioids and stimulants, nicotine, etc. And they found that rats who were exposed to opioids, who were exposed to amphetamines, who were exposed to cocaine, if they were treated with GLP-1s versus placebo, they not only lost their desire to use those drugs, but they did not show signs of withdrawal either. So it was very interesting, very compelling. And so now we're sort of in this new era of testing it in humans for all kinds of different drugs of abuse.
And there's a lot to unpack here, but one thing in particular, you mentioned that for alcohol, it was only working for people that had a BMI over a certain rate. Did they find that to be the same with some of these other drugs of addiction?
So to be determined, those study results are not in yet. We don't really know. And it turns out that some of these medications may be effective at lower doses than what are typically used to lose weight. So the effective dose to treat individuals with opioid use disorder may be half the dose of the minimum that typically people take to try to lose weight. So it's not really clear what's going on. We don't have the results in for those studies. But yeah, I think it's pretty interesting that it's working for individuals who are overweight and obese and may not be working as effectively for thinner patients.
It sounds like people that originally were going on the GLP-1s and they're losing their taste for alcohol, they were not in their doctor's offices seeking addiction treatment. They were seeking treatment for something else. Now, the people that are in these research programs where they are looking at GLP-1s for addiction, are they seeking addiction treatment? Are they taking the GLP-1s for something else? Are they receiving other types of treatment at the same time? What does that look like?
It's a great question. People are wanting addiction treatment who are coming in to get a GLP-1 to be put on the study. They are already on evidence-based medication, which is well-known and life-saving, methadone or buprenorphine for opioid use disorder. With alcohol use, there have been specific studies that are looking at individuals who want to stop drinking as the primary outcome, as opposed to a secondary outcome from weight loss. But I'm not sure if they're also on other medications.
And so you mentioned that not a lot is known about the mechanism by which this is actually working. And I'm a little curious because I've heard about GLP-1s being used for more what we think of as behavioral addictions, like gambling. What does the research look like there? Do we know more about that yet or not?
We don't totally know. This is sort of the modern, more ethical version of the ice pick lobotomy. We're sort of really meddling with deep structures of the brain. It's a very interesting question, but I think at the root of it is what really is satiety and what does it mean to be satisfied? In other words, to no longer have a drive to fill a hunger, fill a thirst, fill some sort of need, whether it be biological need, whether it be psychological need, physiologic need, etc. So it's a really interesting question. And, how much of our personality is based on our impulses, our desires, our cravings, our things that we do on a daily basis, what drives us to get us up in the morning and out of the door. And I've asked myself this question many times, like, what are we doing here? And the bottom line is there are individuals who have a pathologic process in this area of the brain, and it leads to incredibly self-destructive behavior. And if we can give a medicine that takes the gas off of that part of the brain and really treats a pathology, it can potentially open up room for more healthy ways to cope, healthy ways to pursue basic needs that won't lead to self-destruction. And so that's what I'm hoping, but I think that we're following what's happening to people clinically more quickly than we know what's going on with the actual science.
I was going to ask you, is this by itself a viable treatment path, or do you see it as part of, more wraparound services that are addressing all kinds of different addiction pathways?
I think it is a piece of the puzzle. I wish that a pill could take away somebody's traumatic childhood. Unfortunately, it doesn't. And there are a lot of additional supports that people need to recover from a really complex illness. If, however, this keeps them, quote unquote, off the ledge, that's really key to their survival. So, anything that we can do to help individuals engage with treatment, slow them down a little bit, make them less impulsive, and help save their lives is a good thing.
There's been a lot of conversation recently around things like SSRIs and sort of the exit ramp for medications. And you mentioned that people, are doing well while they're on them. Do we know yet what happens when people go off of GLP-1s, or if there is any kind of sort of tapering that's included in the treatment plan?
So with weight loss, we've seen a rebound effect that people will go back to eating. It's not clear what's going to happen with addiction. And the reason why I'm not so certain that it would go by way of weight loss is because we make new memories of how we're able to function when we don't have the constant exposure of drug. That itself can be reinforcing, and perhaps learning more coping skills in a time of relative rest in that part of the brain can strengthen a person's ability to maintain sobriety. We don't know. We don't know what's going to happen here.
You mentioned that there's ongoing research happening right now around addiction specifically and GLP-1s. What is the status of that research? When might we start seeing some results and being able to maybe put together a narrative about how this is working? Are we talking 5 years, 10 years? What might that look like?
So already it's being used in an off-label capacity and an online capacity because there's a huge whisper network about its abilities to potentially help. That's not necessarily scientific evidence. In terms of scientific evidence, I can tell you there have been quite a few phase 2B studies, that's pretty jargony, that's looking at the level of like hundreds of patients being on a GLP-1 to look at different substances of abuse. That's not quite the standard that we look at to get an FDA indication for it. But there's also pharmaceutical trials going on right now, specifically looking at that, really running large, robust, randomized trials to see if they can get an indication for it and a release to market. So that's looking at within the next 5 years. But I'm not suggesting that anybody should go online and, purchase these things sight unseen. We don't know what's actually in the product that you purchase online, and it may or may not help, and it may, in fact, harm. Instead, to do that, I would still go to your doctor and talk about different possibilities. There are plenty of evidence-based medicines already out there and found to be effective for the treatments of alcohol and opioid use disorders. And they are available and they work. So that's the most important thing.
My last question for you is, let's say a patient comes into your office and says, I heard about these medications online. How do you have a measured conversation? And I feel like you've already touched on this to some degree to kind of temper their expectations and also, help them feel hopeful about that this may be something that does work for them.
So for now, it's not something that I'm offering out of the gate. The results are not in yet in terms of its ability to help, and not only that, its ability to help independent of the other medications that we know help for opioid use disorder. So I'll sort of describe it to patients in the same way that I might describe different kinds of cancer treatments to patients, that I'll say, for methadone treatment, there's a 7 in 10 chance that they will still be in treatment at 6 months. It's incredibly effective. It will reduce all cause, so every possible reason for death. It reduces the high-risk behaviors that cause HIV or hepatitis transmission. It keeps people out of prison. And it's just an incredibly effective treatment. And buprenorphine, the numbers are, 50% 6-month treatment retention rate. It also reduces the high-risk behaviors that can cause HIV or Hep C. And I individualize it as much as possible, and I try to help people feel really good about the medications that they choose so that, when it works, they know that they're doing the right thing for themselves. If they are treatment refractory to those medicines and we're, in uncharted territory, at that point, we talk about perhaps untreated mental illness. We make sure that their counselors are on board and are addressing their hierarchy of needs and seeing if there's anything else we can do to either engage them in treatment or try to change their trajectory. If they're interested in joining the study, that's not a guarantee that they actually get a GLP-1. It is a randomized controlled trial, so they get a chance to be randomized to the medication versus placebo. And that's something that we let them know, but it's a way for patients to become more engaged in the clinic as well. And so that itself can be therapeutic. That's why there's something called a placebo effect. So I'm happy to also introduce the study to them if that is something that they might be interested in.
So if I'm hearing this correctly, GLP-1s, there's some hope and promise, but we just don't really know yet.
We don't have all the evidence yet.
Dr. Sarah Kawasaki, thank you so much for joining us on Public Health on Call.
Thank you for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.